hand straight over to you, Dr. Svan, and let you do your thing.
Okay, well, thank you so much, Claire, and the people who've joined us today. I mean, as it's a small group, would it be useful actually to get an idea of what you'll want to hear? Because there's so many different aspects of long COVID. We can talk about how the services in Leeds and how patients are managed. We can talk about outcome measures. This is something which is very close to my sort of heart, and that's what I've been leading on. About the C19 virus. Then we can talk about other research studies which are going on in and around Leeds and what is the current thinking on the kind of various mechanisms and managing long COVID. So it really depends actually, because I don't want to kind of give a very bland talk. So make it interactive and maybe just shout out what you want to hear today. I mean, maybe give me a few pointers and I can focus on those.
And feel free to put it in the chat if you feel uncomfortable. I did see lots of nods when you talked about outcome measures. So that might be a good place to start, and then maybe people can put things in the chat as we go along to see if there's anything else that you want to talk about.
Anything which comes to your mind today I need to focus on? You don't need to raise hands, just shout. I would say it's such a small group. It's a small group. Just jump in.
Yeah, sorry. I'd just be interested to know how the progression is going, and because I'm like 22, 23 months into living with long COVID, and just the progression and what the thinking is, because from my experience, I'm finding that people are saying COVID's gone and long COVID doesn't exist. That's from my perspective. And I have a brother who thinks that exercise will cure it all, and that's not the case. But yeah, that's what I'd like to hear.
Talk about exercise and sort of the long-term trajectory where we're going with long COVID.
Yes.
Anything else people would like to hear?
I don't know if you can hear me. Can you hear me?
Yes, we can.
I had COVID at the very start and was in the hospital for a while on oxygen. I've had long COVID, and within the last 2 months, I got COVID again. And the long COVID has been exacerbated to the point where I can't get my breath very easily. I cough incessantly sometimes, and I get very, very dizzy. And I do go out for walks, and I walk my dog, but I have to walk him half the distance that I used to walk him. I don't know if I'm just supposed to accept this, or does anybody know if it'll get any better?
No, so I think there's definitely kind of, what happens with reinfections and exacerbation of long COVID, isn't it? So that's something we can talk about as well. I saw somebody post something in the chat. Elderly medicine registrar new to the trust have long COVID research. Okay, yeah. So I mean, I think there's lots of slides on research. So let me share my screen with you all. And how much time have I got? Sorry, Claire, how much?
We've got an hour if you want to. We've got till 11.
Yeah, we've got an hour. Okay, that's fine. Okay, so yeah, just so you can see this, everyone. Yeah, okay, so just kind of, if you want to kind of come in at any point, just shout, or because if you raise your hand, I think I can't see, because at the moment I can see only these slides. So just kind of give a shout and make it very informal, please, because it's such a very small group today. So that's me, and I've got those roles, and I must say kind of, in particularly with long COVID, we've done quite a bit of work nationally and internationally, and I also advised to the WHO on the COVID rehab policy in Europe. So some of the things we can cover today, as I said, we'll keep it very kind of what you all need from the talk. to this crowd, we really don't need to be sort of telling the symptoms of long COVID. It's a true multi-system condition across all these organ systems, and no two people are actually similar in terms of what symptoms they get. And there is kind of I think what the other thing to consider is the comorbidity. So if people have certain other conditions prior to getting COVID, then I think those particular symptoms get worse. So people who have COPD, that particular aspect gets worse. Sorry about my emails. I can make that quiet. Just 1 second. I'll just so the people who have predominant conditions prior to contracting COVID, those symptoms might get worse. People who have chronic pain, people who have fibromyalgia, the symptoms get worse. And same applies to kind of psychological problems, brain fog. So we've seen that definitely has a role to play, what predisposing conditions patients have. However, it is a new condition. So the people who develop these symptoms, they can do completely as new set of symptoms, not necessarily just a worsening of the previous symptoms. So we've seen new onset pain, we've seen new onset brain fog, we've seen new onset breathlessness, and that is attributable to the COVID infection. And that is what the definition of long COVID is. So this slide just says the difference between hospitalized and non-hospitalized patients, and you can see that it's pretty much similar. You could argue that the deconditioning part of it is probably more in hospitalized patients, whereas the typical post-viral kind of fluctuating symptomology is more seen in non-hospitalized, but that's a very kind of broad distinction. You can't really use that because there's no literature to support that. Now, again, look at the burden of the problem. Now, we did mention just in the beginning, one of you all mentioned that, well, what's going to happen? COVID has ended and nobody's really seems to be interested in, up till now, there seem to be interest, but then what's going to happen in future? Is there going to be interest? Well, I think the current services which have been set up by NHS England, you've got those 90 clinics. Now they have, so each clinic, so Leeds have got about 1,500, 2,000 patients on the book. So if you think about these patients long term, not everyone is improving. So from our, for example, the Leeds service, we've got a rough statistic that about 60% are improving. But then the remaining sort of 40 to half of them are actually not. Some become kind of, they're able to self-manage their condition. They kind of reach the kind of agreement that, yes, this is going to be a fluctuating condition, but they know how to manage their triggers, and then they get discharged. But then again, there's a big proportion of patients who cannot be discharged because they get, I mean, we heard from somebody else as well who've got a reinfection and the COVID has got worse. And when such things happen, you really can't discharge these patients from the services. They need help every now and then when there's a flare up or when things become worse, or whether there's other kind of medical things which need to be done. So I think all these 90 clinics will have patients who cannot be discharged and who have these long-term, it's a long-term condition. I think we've reached a stage where we've got to say that, yes, some people have this long-term condition. So what happens to these people? So the NHS funded, NHSE funded services, the funding past March next year is not been approved yet. And they're looking for data. So they're asking for all the sites to produce sort of data to see how actually these people, how many people are improving, how many people have got the long-term condition. And I think they will use that data to make a case for further funding beyond March of next year. So by no means long COVID is finished. And I think it's responsibility of us as clinicians, researchers, and also patients to actually make the case to say, well, there is a proportion of patients who do not improve long term. It could be 30%, 20%, we don't know. That's what we are researching on. And when you just work out the math in terms of, well, let's say, as you've got that in that slide, you've got about 30 million worldwide who have persistent sort of symptoms beyond, say, 3 months. Now, out of which less than 1 million in UK, and if you say half of that, you've still got a big chunk of about 300, 400,000 patients across the country who will have this long-term condition, and it's a new long-term condition. So basically, I think there needs to be more kind of reports which are produced to NHS England and to NICE and to other authorities to say that we've got this proportion of people who suffer with this long-term condition. We need dedicated services, or we need the existing services who can kind of absorb these patients. But we need a long COVID management policy, because looking at how the trajectory is, I don't think this condition is going to completely settle in this group of patients, and whatever it is, it's 300,000 or 400,000. So I think, well, that's what will happen. I think there will be researchers like myself and clinicians will make a case to say, well, we've got these sort of number of patients who need management long term, and we need dedicated set of policies, services, and funding to manage these patients. And not to forget, there is an enduring multimorbidity, because there is also end organ damage, which is seen. So pulmonary fibrosis, cardiac damage, and the other symptoms we mentioned. So, so there is the symptomatology to manage. There is also organ damage to manage, particularly the ones who've been in hospital. And this is here, and these patients, will unfortunately struggle with these symptoms. But I think, like any other long-term condition, the key is how to manage it. How do you manage your fluctuations? How do you keep the condition under control? And that is the key. And I think that is what services and healthcare professionals are for, to provide that advice on how to manage and stay within the kind of manageable limits for the condition. And that is the most important challenge, because I think I'll be lying if I say that there will be a treatment and everything is going to disappear. That's unfortunately not going to happen, because we've seen that with chronic pain. We've seen that with so I do a chronic pain clinic as well in LTHT, and so we've seen in that chronic fatigue syndrome, we've seen with that as well, that it is a long-term condition. But if it's managed well, people really lead productive, functional, and this is real experience from my clinic, that if it's managed well, people actually can lead completely productive lives. For that, you need to know the condition kind of, inside out. So that's the kind of the definition. It needs to be 3 months. So post-COVID, we call it post-COVID syndrome. That's a scientific term. And WHO calls it post-COVID condition. And it is symptoms which are present 3 months after the onset. You need to have the symptoms at least for 2 months. So I'm guessing the people on this call today, they fit in that criteria and cannot be explained by alternative diagnosis. Now, that's something I actually don't like. I've written to NICE that they need to get rid of it. And I'm sure you all will agree as well that, there's always this constant emphasis that we need to rule out other things. We need to rule out other things, do all the blood tests and do this and that, do that, do a scan. But then that is kind of a vicious cycle, isn't it? Then you always are chasing other diagnoses. If you've had COVID, and if you had new set of symptoms after COVID, and if they are lasting more than 2 months, and if this becomes a fluctuating condition, well, that is long COVID. You actually don't need to keep excluding other diagnoses. And even if you pick up other diagnoses, let's say you do a scan and you pick up myocarditis, you won't be diagnosing the patient as myocarditis. You would diagnose the patient as long COVID with myocarditis. So really, you don't need to exclude other diagnoses. I think you need the key thing, as we've written in BMJ a lot recently, that you need the GPs, particularly, you need to make a diagnosis. You need to talk to the patient, pick up their symptoms, use some of the screening tools, and make a diagnosis, because that's very powerful. You make a diagnosis, then the patient knows what to do with it, rather than saying, okay, we'll do another scan on you, we'll do a 24-hour tape on you, we'll do an echo on you, and then you're left in limbo for 3 months, and you don't know whether you've got long COVID or not. So I think you need to make a diagnosis, and don't get too fussed about excluding alternative diagnosis. So I'm pushing for that term to be removed really from the diagnosis. It is a relapsing remitting condition. There is post-exertional symptom exacerbation, which you all know. It's a new term for PEM, which is if you exert yourself beyond a certain limit, then basically you crash. And I'm sure everyone on this call will agree that is a hallmark of long COVID or post-COVID syndrome. Which almost kind of distinguishes it from other conditions that if you and it's actually very characteristic of post-viral syndromes. Now, not to forget, this is not the first time something like this has happened to us. This has happened after SARS, this has happened after MERS, this has happened after the Spanish flu. So all the kind of viral outbreaks people have had, there's been a sequelae, there's been post-viral syndrome. And the kind of chronic fatigue syndrome and the fibromyalgia syndrome and the chronic pain syndrome, these are all the long-term sequelae. Now, obviously, nobody's proved that, but this is what we think is happening because of all these kind of medically unexplained people, so as to say, the dysautonomia is actually a sequelae of the post-viral syndrome, which is just poorly understood. And I think more needs to be done to understand what exactly is going on in the immune system, what's happening in the autonomic nervous system, and is there a good approach to manage these patients so that people can not have all these crashes and people can manage their condition better. Now, I think I've talked for about 10-15 minutes. Are there any questions, or do you want me to just carry on?
There is a question in the chat. Forgive me if I'm saying this wrong.
So I need to come off. Just 1 second then. So I need to come off.
I can read it out to you, don't worry. Do you know much about long COVID, and is it POTS? I apologize if I'm saying that wrong. POTS?
Yes. So I'll cover POTS in a bit, and POTS is basically autonomic dysfunction. And if you hit certain criteria on the autonomic dysfunction, that your heart rate, it goes up by a certain number when you stand, then you fit the criteria for POTS. And so that is kind of one end of what is called the autonomic dysfunction, where there's a imbalance between your sympathetic and parasympathetic system. Do you want me to cover it now or come back to it later?
It's entirely up to you. Just so you know, you are sharing your screen still.
Oh, okay.
And it's not your slides.
Okay.
And then I'll pick up the point about the slides later on, Suzanne, if that's all right. So I'll hand back over to Dr. Savan.
Okay, yeah. So so basically what we think, we don't know the exact number as to how many people have autonomic dysfunction, but it's quite high. So we did a study recently where we looked at to what extent your blood pressure and your heart rate fluctuate with position. So doing the lean test. And we found that about 13% actually fit the criteria for POTS, which is your heart rate needs to go up on standing more than 30. So when you're lying down, you take your BP, you take your heart rate, and then you stand up, and then for the next 10 minutes, you keep recording it. And most of the changes happen in the first 3-4 minutes. And it needs to be a stress-free environment. You're on your own, so that there's no kind of anxiety-provoking stimuli. And if your heart rate jumps up by more than 30, then that is POTS, basically. You're symptomatic. You feel dizzy and you feel palpitations and things like that. So that is POTS. And if your blood pressure drops more than 20, then that is orthostatic hypotension. So those are the two extremes. But then there are, what we found is there are about 50-60 kind of percentage of people who have, let's say, increase in heart rate between 20 and 30. Now, POTS is a very specific criteria with a specific cutoff. But then even 20 is not normal. So if you don't have any symptoms, if you're a healthy volunteer, if you do that, your heart rate might go up by about 15 to 20, not more than that. So sort of 20 is the cutoff. So people between 20 and 30, they have elements of autonomic dysfunction, but it doesn't fit in the criteria for POTS. And this is the challenge in kind of long COVID, that we need to put that message out to say, if you don't hit the criteria for POTS, doesn't mean you don't have autonomic dysfunction. You do have, if you're still between the kind of the 20 and 30. And obviously, you've got to do that with different stimuli as well. You want to do that with food, you do that with exercise, and yeah, those are the two main things. So it's position, exercise, and food. And there's a autonomic profile test which we've developed called AAP, and I'll talk about that in one of the slides later.
Thank you.
Okay, shall I carry on then if there are no questions, comments?
Yep.
Okay, so 10:20. Let's so we are there. So yeah, we talked about it, not a diagnosis of exclusion, and then is the symptom exacerbation linked to the onset? So again, so this is again about diagnosis, that are your symptoms linked to the onset of that viral infection? There's no confirmatory lab tests, and that even for the definition, we said, probable as well. So you don't have to really, to prove that you've got long COVID, you don't have to have a confirmed PCR test. So even if you had possibly a COVID infection, especially the ones in the first wave where there was no testing, but if your symptoms are clearly from that date, then that is enough actually to make a diagnosis of long COVID. Now, the Leeds Long COVID Service, it's just kind of, some stats there, that we were one of the first long COVID service to be set up. It was one of the first studies we did, and one of the first prompts really we developed, which is now used, which is recommended by NHSE and also NICE, and there's, it has been translated in various languages. We'll come to that in a minute. Now, this is something key, actually. So if we've got some healthcare professionals here. Oh, sorry, we are all healthcare professionals. So if you see here, this is how the standard pathways is that, in the hospital trust, you've got a specialty, and then patients getting discharged will go to the community. In that track, they will go to the GP, and then there are some specific services, like there is pulmonary rehab in the community, there's neuro rehab, there's MSK rehab, there's psychology. So patients go, then present to the GP to say, oh, I'm still struggling. Then they get referred to pulmonary rehab. So let's say you've got COPD. If you've got a neurological condition, you get referred to neuro rehab, and then you're managed. But we've got a condition which is so varied, it's multi-system, and this is the problem, because we don't have anything there which can actually manage a multi-system condition like this, because clearly respiratory medicine can't be managing long COVID with all the kind of autonomic fluctuations we talked about, where you need probably a cardiologist and other specialists. So because it's so cross-cutting between the specialties. And this is how the service now looks like. And you can see it's so complex now, but it's nicely done in Leeds, that we've got that MDT, where a select number of cases are discussed every week, where there's a cardiologist and there's a respiratory medicine physician, there's psychology, and then patients, based on their needs, are then directed towards services which can meet their needs, because, as I said, every patient is different, and you need these triage points where you can use our scale, the C19 virus, to actually figure out what patients' needs are. And if they are truly multi-system, requiring those specialists, then it goes to MDT. Otherwise, it goes to these services. So this is what is called as a integrated care pathway, where there is a cross talk between the various specialists. And, we've written in BMJ about it, saying NHS needs to rethink. Given long COVID, we need to rethink how we work, because I think just working, and if you just go back to this, now this will apply to any long-term condition, if you think about it, because any long-term condition doesn't actually restrict itself to just one organ system, because that is the nature of the condition, that you start getting complications in other system, and so multi-morbidity. We've got an elderly care physician on call today. I mean, she will know very well how multimorbidity presents itself. You've got to manage all these conditions, kidney problems, you've got to manage lung issues and dementia all together. So you need that sort of, integrated care pathways to manage. And I think this should become how services are managed. You just can't have one specialty track managing patients. And that is good for NHS if we start thinking about these integrated care pathways. This is how the MDT works in the long COVID service. You've got those professionals, and you've got, as I said, respiratory medicine, cardiology attending as well. You got to look at red flags. So we've written recently in BMJ, we did an update for long COVID. So I would really recommend all of you to have a look at it, or otherwise just email me. I'll share you. It's freely available. It's open access. And it talks about, well, what are the red flags which you need to really, if you're getting exertional chest pain, which is not actually is something new, then you've got to rule out the cardiac problems, and that is a red flag. If you're really, your brain fog is so bad and you're feeling so low and down that there's some suicidal thoughts, that is a red flag. If you're desaturating rapidly on your pulse oximeter with minimal exertion, that is a red flag. So these are the red flags which need, going to that MDT discussion and then further investigation, scans. If you've got an arrhythmia that needs a 24-hour tape and an echo. So that those kind of things are red flags, which are, which you all will know very well and needs to be flagged up to the relevant specialists. And then you need an individualized management plan, because as I said, no two patients are the same. So you just can't have one treatment for long COVID or one booklet which you just hand over to everyone. You need to have that individualized assessment to understand what their needs are, and then cater to those needs. There is group therapy as well. So once you've done that initial triage and you feel it's safe to actually put people in a group, then you can do that. And you all know that long COVID, the Leeds service have got these kind of group virtual rehab sessions where there is different modules, and then you can choose between the modules what to attend. This is how some of the symptoms can be managed. And again, I don't think we need to really go into the depth of how each symptom is managed, because that again is a separate talk on its own. But it's just to say that you can have that approach that if there's a one particular problem, then you approach that and see whether what needs doing. Now we had somebody's staff member saying, they are becoming more dizzy and they're becoming more cough, and there's a reinfection. So that needs kind of proper investigation to see whether this is exacerbation of long COVID, or is there a new complication. Now, how's the lung doing? Has there been a chest X-ray done? Are there new findings on the chest X-ray? Do you need a further spiral CT? Do you need to rule out heart failure? Do you need to do the pro-BNP in them? And then look at, mentioned about dizziness. So what's the autonomic function doing? Do we do a lean test or an AAP to pick up the autonomic dysfunction? So this is the kind of assessments which are needed to, our colleague who mentioned that his symptoms have gone worse since the recent COVID infection. So that's the virtual rehab program with those different modules led by different kind of therapists, which are very useful. I mean, they seem very simple, but they're very powerful as to how to manage your symptoms. For example, the pacing is so important. How do you pace yourself? And so that you don't have those crashes, so that you don't have those relapses, because that is a key. I strongly believe that the more you crash, the more episodes of PES you have, actually you're prolonging your recovery. So I would say you need a good kind of 2 months of not having any crashes to improve your chance of recovery. And you'll all agree that that is just not possible, because any amount of exertion you have, then you tend to have the relapse of symptoms.
Can I just jump in there?
Oh, yeah.
Would you go back to that slide, Dr. Spang? Because I know there's a couple of people on this call that are still.
This one?
Yes, please.
Yeah.
There's a couple of people that are still waiting. They're still on the waiting list. Sorry, stop sharing now.
Oh, sorry. Okay.
They're still on the waiting list for the rehab service, and I've heard some amazing things from the rehab service. And I know that each patient is individual and needs that bespoke assessment. Fully appreciate that. But I think that slide you've just shared with those top 8 high-level ways of supporting yourself, I think, has anybody got any more questions around that? Because I know that's where some of you are struggling. When we talk about this being a long-term condition and we talk about helping ourselves in the best possible way, is there any of those things on this slide now that anybody wants Dr. Sivan to talk a bit more about?
Yeah, sure. Yeah.
Because we throw things away, don't we? Go have good diet and nutrition. Well, is there anything in particular that is could be really, really great for people to support people? The importance of sleep. Is there a recommended amount of sleep we should be getting, or again, is it very bespoke?
Well, I think good sleep is you need to feel refreshed in the morning, and if you're not feeling refreshed, that means, you know, the sleep quality. I mean, it's just not the amount, isn't it? It's about the quality. So if you wake up in the morning and you just feel again groggy and you don't feel rested, that means something is not right, that your sleep is not of good quality. So I think that I would use that as a marker of how you're feeling. If you wake up and you just feel tired as if you've not slept, then that means your sleep is not of good quality. So then you need to work on, well, you know, the basic sleep hygiene stuff. You know, how's your room? You know, the noise free, you know, gadget free, and is there gadget free in the sense you're not looking at flashing lights before you sleep, and then, you know, avoiding stimulants before you sleep, avoid smoking before sleep, and whether there's any kind of relaxing music or alpha kind of, you know, meditation kind of stuff you can use to sleep. And then sometimes medications do help. So I do prescribe things like amitriptyline or pregabalin to actually calm down and help with sleep. So it's a combination of things, and every person is different. Sometimes they don't want, some people don't want medication. They just want to focus on the normal kind of non-pharmacological sleep hygiene. Some people really want to break that cycle, and then a course of amitriptyline can help break that sort of, you know, that vicious cycle of not sleeping. And if you talk about some people like, you know, Graham Burns, who's the NHSE clinical lead for long COVID, he thinks that the whole long COVID is a sleep problem. I don't agree to that, but it is a big issue, sleep, and you you know, you need to focus on that, because clearly if you sleep well, you feel better the next day, and then you tend to kind of break that cycle. And it's very important to break that kind of vicious cycle. You get stuck in it, that you're not sleeping, and then your symptoms get worse, and because the symptoms are worse, then you're not sleeping, and then you're getting more depressed, and unless you're relaxed and you're able to kind of that sort of meditate, I think it's very difficult to get good sleep. Sorry, that was just on sleep.
Yeah, no, that's a really great answer, because
yeah, I mean, I would say pacing is the key, really. And as I said, it's about avoiding those crashes. I mean, could I ask actually whether there's anyone on this call who doesn't have that kind of characteristic pattern of crashing? Is there anyone on this call who just think they have constant symptoms, but they've not had those typical episode of if you exert, you crash, and then it takes you days to kind of recover? Is there anyone who doesn't have that pattern? No. So looks like, you know, that is the I mean, that is the key, I think. And would and if I were to say, have any of you actually had a good 4 weeks without having any crashes? Have you had a 4? You have.
I have, yes.
Oh, right.
I have. Just recently I had 4 weeks where it was really good. I had a good night's sleep and everything else. Then Friday I had to come for results to the hospital, and then Friday, that was it, Friday afternoon, and all weekend I've just slept. Not slept during the night, had broken sleep and what have you. So it's gone back to that pattern, but I did get 4 weeks solid, and then it's gone back.
And how were you feeling those 4 weeks when you didn't have any? Were you feeling like really kind of recovered from the condition?
Full of energy and thinking, great, I've cracked this. And then all of a sudden my body's just gone, no, sorry, no, you're not doing that.
And what happened on Friday then?
Well, I had to come to the hospital for a result, a test result and what have you, and I had to be there for 9 o'clock. And then I decided it was good news. So I decided, right, I'll go shopping. First time I've been shopping in, oh God, I don't know how long, basically. And I went shopping, and then I came home and I thought, I can't be bothered to put the shopping away. And I left the shopping, sat down with a glass. I thought, I'll have a glass of water, see how I feel and what have you. The next thing, I was asleep. and I was asleep for about 4 hours. So it just literally came on all of a sudden. But again,
I mean, do you think you overdid it then on
yeah,
Friday?
probably, yes. Yeah, but I needed food. So, and I'd left it too late to get an internet shop. So I needed some food. So it was a case of, right, I need to do it. But I did overdo it. It was relief.
And you've not recovered from it yet, is that right?
I'm quite groggy this morning. I'm not as bad, but I still am quite groggy this morning. But I know when I finish at 3:15, I know I will be asleep. You know, but again, I'll start and manage, like you said, I'll start and manage again, and hopefully I will recover from, you know, from that. So hopefully that'll happen. So fingers crossed.
Well, I think this is a great question actually, as to how do you know, you know, when you're having good days, at what your limit is. Well, I think, you know, it's very difficult to answer that, isn't it? I think you need to maintain a diary, because whatever your previous crashes were, the only guide could be what triggered those crashes. So for example, on Friday, whatever you did, I think you need to write that down, exactly what happened, and figure out what was done more on that particular day. Was it the shopping bit, or was it just the stress of rushing 9 o'clock to get your result? I don't know which one triggered, but one of those two has triggered this, and I think that needs to be avoided maybe going forward. So it's just like that. I think it's self-management, isn't it? You will know what your sort of envelope is, your energy envelope is, because that's different for each person. And I think maintaining a diary would be the best way of understanding what your limits are.
Thank you.
Do people go into work if they have long COVID symptoms? Well, no, you shouldn't. I know there's lots of issue around, you know, what you're entitled to and not. But I would argue it this way, that let's face it, if you don't manage your long COVID symptoms well now, then you're walking into a long-term condition, isn't it? So your best bet is now, where you try to avoid those crashes and make the most of it, and you will know what your limits are and what sort of work you do. If it's it's physical work, or it's, you know, mostly cognitive work, what are the stress levels, how long is the shift. So you've got to have this discussion with the employer to say, well, this is what the evidence is, that I need to avoid these crashes, and if this is my limit, then I can work, I don't know, 3 hours or 4 hours a day from home, something like that. If the job is at risk, then you've got to work around it to see what would be permissible by the employer. But the key thing is, your work shouldn't be causing you to actually crash, because then you're just prolonging your recovery. If you keep crashing, you're prolonging your recovery. So I mean, you know, it's a difficult choice to make. And hopefully the occupational health would be supportive about that. If they're not, I think it needs challenging.
I think this is a really tricky one at the minute, Dr. Savan. I think people are really torn between getting paid and their health. And I think I see lots of people nodding on the call. So prior to the 7th of September, anyone living with long COVID got paid. And then the government changed those rules. So I think it's great that it's starting to be recognised now as a long-term condition, because I think that will really help employers to understand it a little bit better. But it is that balancing act, isn't it? And I have spoken to many members of staff who are actually going, I don't know if this is the job for me anymore. And that's heartbreaking when you've trained so hard to, you know, to do the profession that you love to do. But it really is a challenge. I think a lot of people are struggling with, you know, mentally with anxiety about, I need to eat, but I also don't want to make myself poorly.
Absolutely. And at the same time, I think we need to all be very pragmatic about it, because if you all have had this condition for more than 12 months, then, you know, it's very unlikely that it's just going to disappear just like that. It's not going to disappear. It is a long-term condition, and you've got to, you know, reprioritize all your commitments and see what is it that you can do and stay within the limits. Because if you keep overdoing stuff, and if you're doing more harm, then long-term chances of recovery are even more poor, isn't it? So I think it's time to make that call. If it even involves changing roles, why not? I would say, because at the end of the day, you know, you got to look after yourself, isn't it? And then make a good recovery. I find that I use all my energy for work, including 12-hour shifts, then have no extra energy for anything else. If I try and do anything more, then I crash. Well, I think that is good though, if you're managing to do 12-hour shifts without crashing. So that is good sign, I would say. I will take that very in a positive way, and don't do the extra stuff. Leave the extra stuff to somebody else to do. If you're able to hold on to a 12-hour shift without crashing, I think it's fine. Only even if you don't do anything else. I mean, yeah, I mean, it's difficult if you have kids and things like that, but that is a good sign if you're able to do a 12-hour shift, because most of the people I hear, they can't manage even like anything more than a 4-hour shift. They won't be able to manage.
And I think it's balancing it as well, isn't it? I mean, if you're doing a 12-hour shift and you've literally got no energy left for a personal life whatsoever, it's looking at that 12-hour shift and go, right, I know I can do a 12-hour day, so maybe I need to reduce my hours at work so I do have time for me and I do have time for my family. And again, really tough decisions to be thinking about.
Yeah, but at least it's saying that you don't need to leave that. I mean, whoever this is, you don't need to leave your job, looks like, if you can do a 12-hour shift without crashing. That is good.
Yeah, I already work less than full time.
Sorry.
I already work less than full time.
Oh, okay. So
I'm doing fewer 12-hour shifts than other people would be doing.
So if that's the case, could you not actually avoid those 12-hour shifts and just do 8-hour shifts?
It's really tricky because then I need to be able to complete my training to be able to.
Oh, so you're elderly medicine, are you?
Yeah.
Okay. But why can't you do those kind of things later in your training? So this is a period where you're kind of consolidating your recovery. So could you not do a year or so of avoiding those shifts, and then maybe, once you had a good recovery, have a go at that later?
It's already been 2.5 years, so.
True, but I don't think you should really, I mean, you should be careful at this point, isn't it? Because you're doing well, I think. You don't want to kind of, undo the good work you've done so far. Sorry, I find I'm more likely to crash after working from home, such as online training day and concentrating all day rather than going into work. Well, I mean, this is just coming up, all the time in our work, in our research, that when you look at the triggers, people always focus on physical work, but actually cognitive and emotional triggers are equally kind of damaging in terms of the relapses. So we looked at patients where we asked them to actually say what their triggers are for relapse, and we were actually shocked to see that it was all equal. So if you have physical, if you have cognitive, and if you have emotional, it's pretty much the same. We expected a lot of people to say physical work, but actually it's not. So that is again a valid point, and I think the same rule applies for online working and concentrating as well, that if it's 8 hours is your limit, or let's say 4 hours is your limit, I think even that online work from home should be just a 4-hour shift, I think. And I think you need to make a call as to what your limit or what your envelope is.
We've got about 15 minutes left. If people want to go to questions now, I'm going to stop recording. I'm just conscious I did say you would have a safe space, so I'm going to stop recording and then leave it open.